My name is Becky Young. I'm going to be the moderator today. I'm the Director of Marketing and Communications at St. Francis-Emory Healthcare. Today's virtual Lunch and Learn is Meet the Midwives, Why Midwifery? And I'm going to introduce each midwife, and if you'll just raise your hand when I introduce you, and I'm going to read your bio as well. So our first midwife is Bettina Fairley. Bettina Fairley is a board-certified nurse midwife whose own personal experiences shaped her desire to become a midwife. Bettina gave birth to her first child at age 19, followed by her second child at age 21, both by cesarean section. While Bettina's birth experiences were not what she hoped for, she vowed to make sure that other women had better birth experiences than she did. Bettina's career is driven by her faith and believes it is to be such a privilege to be present when new life enters the world. She believes in the power of a woman's body and empowers women to listen to their bodies. Bettina earned her master's degree in nurse midwifery at Frontier Nursing University and her bachelor's degree in nursing at the University of Southern Mississippi, Long Beach. Bettina has spent 12 years in healthcare as a registered nurse and certified nurse midwife. Her selfless service to others involved 5 years of active duty service as an officer in the Army, providing care to service women and spouses of service men. Bettina is a native of Mississippi. She lives in Phoenix City with her 2 daughters. Bettina enjoys attending worship services at Casita Road Church of Christ. In her spare time, she also enjoys home decorating and spending time with her family. And next, I'll introduce Melissa Hatter. Right? Good. Melissa Hatter has been a certified nurse midwife for over 8 years. She started her midwifery career in Montgomery, Alabama, and moved to the Columbus, Georgia area in 2017. Melissa chose to go into midwifery because she believes that making an impact on a woman's health will have an impact on her entire family. She focuses on empowering women through education and supporting them as they make decisions about their health care. In addition to her midwifery work, Melissa is active in the community and her local church body. She is married to her amazing husband, Aaron, and they have 3 boys who keep them very busy with school and sports. One of Melissa's favorite hobbies is reading, and she especially loves picking up books at the little free library book stand in her neighborhood. Next, I'll introduce Melissa Terry Fish. Melissa Terry Fish found her passion for pregnancy and motherhood at age 10 when her mother was pregnant and gave birth to her younger sister. She knew from that early age that she wanted to be a nurse and eventually a nurse midwife. Attending Vanderbilt University and later the University of Alabama, Birmingham, Melissa realized her dream of caring for women and families. A certified nurse midwife since 1992, Melissa has practiced here in Columbus for 20 years. She is married and the mother of 3 adult children and recently welcomed her first grandchild into the family. She and her husband, Anton, have 3 dogs, 8 chickens, and 2 rabbits and are slowly building their dream home on their farm in Talbot County. In addition to midwifery, Melissa has a passion for home and furniture renovation projects, cooking, growing and cutting flowers, and has recently pursued watercolor and acrylic painting in her free time. And last but certainly not least, we're going to introduce Joy Boyce. Raise your hand, Joy. Joy grew up in a small town in Minnesota, went to college in the Blue Ridge Mountains of Virginia, and has lived in Georgia since graduating. She began her nursing career over 12 years ago at Children's Healthcare of Atlanta, Eggleston Emergency Department. During her time there, in the ED became a level 1 trauma center. At the same time, she realized that she really enjoyed educating and working with the moms of her pediatric patients. So she switched gears and started working in labor and delivery in the Columbus, Georgia at the medical center, now Piedmont Columbus Regional. She ultimately finished her master's degree in nursing as a certified nurse midwife from Frontier Nursing University. Now a midwife in her 5th year of practice, she says she can see herself as a midwife forever. Her favorite part is walking with women, which is what midwife means, through their health journey, providing education, informed choices, evidence-based options, and encouraging them to be an active part of their own health care and decisions. When not at work, Joy prefers to spend her time outdoors, running, hiking, skiing, traveling. During the week, you will find her raising her 2-year-old, listening to music, and probably at Bible study. Welcome, ladies, and thanks for joining us today. We appreciate your time. We are going to kick it off with some questions, and I may direct the question to a certain midwife, or if you feel compelled to answer, just raise your hand and unmute yourself, and you can answer. So I think I'm going to direct this question to Melissa, but certainly the rest of you, I should say Melissa Fish. So certainly the rest of you can chime in on this as well. But the first question is, what is a midwife?
Well, a midwife, a nurse midwife is a nurse who's gone back for extra years of education to take care of normal, healthy women from the time they go through menarche or start their first period through their lifespan. And midwives can do contraceptive care, annual checkups, gynecological problem visits. We do, of course, pregnancy, labor, and birth care. Many midwives do menopause care as well. So pretty much anything throughout the lifespan of women. The focus being primarily on normal, healthy women. And so it is important for midwives to work closely with a group of physicians or an individual physician, so that then when there are things that are outside the realm of norm, we have someone to consult with and collaborate with and potentially refer to manage those abnormalities. So again, we focus primarily on the normal. We do lots of anticipatory guidance, lots of education. We want women to know about themselves. We want to empower you to take the best care of yourself that you possibly can, so that you can have a normal outcome in whatever stage of life you're in. So basically, in a nutshell, that's midwifery.
Great, thank you. Would any of the rest of you like to chime in, or has Melissa covered it?
I mean, I think she pretty much said it all, but, you know, it does encompass what we do is so great. I mean, you take care of the woman, not only physically, but you take care of her mentally, emotionally, spiritually, even culturally as well. So I think she hit the nail on the head with what midwifery is.
Thanks for adding that. Okay, I'm going to move on to the next question, and I think I will ask Joy to answer this one. What type of education does a midwife have?
A midwife will have a bachelor's degree, usually in nursing, and then a master's degree in nursing as well, with a specific path for nurse midwifery. So that's generally, and then you take a national board certified test to become certified as a certified nurse midwife. A lot of midwives now are getting their PhD or their doctorate of practice, and that's also, you know, certainly a good option for working as a midwife. But generally, that master's degree component is a requirement to practice.
Great, thank you. I'm going to ask Melissa Hatter this question. What type of patients do you see?
So this kind of goes along with what Melissa Terry Fish was describing as far as the role of a midwife in women's health care. We are trained to take care of women's health from menarche to death. And there are some midwives who specialize in menopausal issues and health concerns. Primarily in our clinic, what we see is younger women up through age 40-ish. You know, we do have some women who are over age 40 who are maybe existing patients or who really want that midwifery touch in their lives. And so we don't have a strict age limit. Some midwives will see patients all the way up through menopause. Sometimes we consult with our physicians if we have menopausal patients or perimenopausal patients who have questions that we're, you know, not as comfortable answering or taking care of in the long term. But we can do annual exams, we do pap smears, STD screening, that sort of thing. So those are applicable, for years and years throughout a woman's lifespan. We do pregnancy care, and there's some women who are having babies who are up into their 40s. So we do take care of women during pregnancy. I see a fair number of adolescent women who are coming in for preventive medicine type visits, just to talk about birth control, talk about, sexual activity, deferring sexual activity, safe sex practices, that sort of thing. So even if you just come in because you're having problems with your cycles, I'm still going to talk to you about safe sex and abstinence and that sort of thing, because we don't know when you'll come back to us. We don't know who else is talking to you about that sort of thing. So we definitely want to make sure that you're getting, the appropriate education and have all the information that you need to make the right decisions for your body and for your health. So we do see a wide variety of patients on any given day. I may see patients who are having problems with their cycles, who are having, symptoms of an infection. We may be seeing normal OB patients. We may be doing annual exams and preventive medicine. So it's really a wide variety of patients that we see on a regular basis.
Thanks, Melissa. That's a great response. Another question, just to follow up with that. So if someone wanted to, say, have their first annual exam, say they're a teenager or in their early 20s and they're coming in, would they just request a midwife if that's who they want to see, or how would they do that?
Yeah, so absolutely. You don't have to have a referral to us from either a primary care provider or a pediatrician. Now, we do take referrals, so especially from pediatricians, if they have an adolescent woman who is having some concerns and they want to refer them to us, we love that. We'll take it, and so if you have someone who wants to refer you, that's great, but it's not required by most insurances. And so they can just call our main office number and request an appointment with one of the midwives. If they're a brand new patient to the practice, then they'll have some options there. If they're an established patient, we usually will put them back with their, established provider, unless there were some questions and they wanted to talk to somebody else. We can certainly accommodate that also. So yeah, they just call and ask for a midwife if they want an appointment.
Great, excellent. I want to take this moment just to remind anyone that has joined us online that if you have questions, please send them through the chat, and I will filter those through to the midwives. So don't be shy if you have a question. And with that, I'm going to just continue with the other questions that we have received previously. So how have you adjusted to the COVID changes, or what can they expect during this time of COVID? And I'm going to put this question to Bettina.
I know that, and I think most of the midwives, we've been doing this, is because of the virus. We know that there are some patients who are hesitant to come into the clinic. So sometimes what we'll do is schedule them for like a televideo visit. That's been one adjustment that we've made. And then I know for me, I've had some patients, it's been rough because they haven't been able to have their support persons here, physically here. So what I've had them do, hey, pull them up on FaceTime and let's have them still be a part of the visit, although they can't physically be here in the clinic.
Yeah, I think that's a good point to make, that while during visits they cannot have that support person with them, but they, during the birth of their child, they can have one support person. But during the visits, and you guys have done a great job of still communicating with the families and helping them still be a part of it. The other thing is, while this virus is going on, what can they expect when they come to the office? Do they, I know they have to wear a mask. Will they be screened, temperature checked? What kind of things are being done to keep them safe and keep you guys safe?
So we are screening visitors with the temperature check and also symptom check. Our visitors are wearing masks, as well as providers and all staff at the office and in the hospital. And you'll see providers with the face shield on as well. And also, lastly, you had mentioned that in labor, you are allowed one support person that stays the whole time. They don't leave, and you cannot have other visitors besides that one support person. So, which is, just accommodating to, like you said, the virus infection protocols to keep everyone safe.
And the other thing with that is we are also doing the COVID testing for patients that are admitted to the hospital in labor. And a lot of people have expressed displeasure about that because of the discomfort of the test. But I want people to understand that there are some specific complications that can happen, particularly if you are COVID positive and pregnant and recently delivered. And so if we know that and can help prevent those specific complications by giving you appropriate treatment, then we're doing our best to keep you safe and help you stick around for your baby. It is not a goal to make you uncomfortable by testing you for COVID. Our goal is to help make you as healthy as possible and help be sure that you recover appropriately. So there are definitely some specific complications that we're trying to prevent when we diagnose you with COVID and treat you around your labor and delivery time.
Yeah, I think that's a good point to make, that while the COVID test may not be the most comfortable thing to have done, it is tolerable, and the reward is, one, whether you have it, and two, if you do have it, you're right, there's some very specific things that have to happen to protect you and your baby and the team members that are helping you. So I tell people all the time, because I've personally been tested for COVID, it's just a moment of unpleasantness, but it's a relief to know what your health is.
In the beginning too, Becky, we had some guidance that maybe said there were some specific situations where we should separate moms and babies who had COVID. And now we're actually turning that around and knowing that we do not need to separate moms and babies. So don't be afraid that if you test positive, you're going to be separated from your baby. We're learning more every single week about this disease process, this virus, this transmission, all of these things, and the ways to treat it. And so, the more we know, the more this evolves. It's very frustrating to all of us because it feels like the rules change every single week, and they do, because we're learning more every single week. But hopefully, we're learning more and doing better for you as a patient.
Right, I would agree with that.
Well, and like Melissa Fish mentioned, we're not separating moms and babies, and that includes that they're still able to breastfeed, that they're still able to nurse directly at the breast, that they're not having to pump and use a bottle unless there are other indications for that. We do ask that moms who are COVID positive or who are symptomatic wear a mask and wash their hands thoroughly, which, hand hygiene is always important anyway, but that helps to reduce the risk of transmission to the baby. But there's no evidence that the virus transmits through the breast milk. And we all know that breast milk has a lot of protective effects. So if anything, this is even more of a time to push breastfeeding and to encourage breastfeeding for moms who are concerned about infection, because it does not increase the risk of transmission as far as we can tell. And it may actually provide a level of protection for the baby also.
Right. So what other questions are you getting, or concerns that you're hearing from birthing mothers or pregnant mothers about COVID that you want folks out there to know?
I think one thing that people have asked about a few times is the risk of their exposure at work. We don't really know a lot about what coronavirus infection in early pregnancy, what kind of effect that will have on the pregnancy long term, because if you look at how long this has been in our country, any woman who was in her first 3 months of pregnancy when this started is just now getting to term. And so we don't really have a lot of good evidence about what the coronavirus infection in early pregnancy may result in. And so we do have a lot of women who are concerned about going to work and being out in public. And what I would recommend to them is, certainly discuss your specific concerns with your provider, but also talk to your employer about what they're doing to help protect you, because it's in their best interest to protect you when you're at work so that they can continue to have you, do your responsibilities and continue with their business also. But, just like with everything else, wear a mask, hand hygiene, keep your workstation clean and sanitized. If you do have symptoms of infection during pregnancy, like Melissa Fish mentioned, there are some specific complications that we look for, and so you definitely want to let us know. Please call us before you come into the office, though, because we can usually do that sort of a checkup over the televideo, and we don't really want you to come into our office for the first 2 weeks after you get sick with coronavirus, just because of the risk of infection with other people. So we do encourage mamas to continue working unless they have other pregnancy complications, unless there's a specific, risk factor. But there are some guidances out right now that say that women may want to start maternity leave 2 to 4 weeks before their due date so that they can self-isolate and reduce the risk of being coronavirus positive at delivery. So that's something you would definitely want to talk to your providers about.
Great. Thanks, Melissa. We have another question, and I don't know what these letters stand for, but you ladies probably do. The question is, do you take care of patients post VBAC, VBAC? Bettina, do you want to answer that one? I think you're on mute.
Can you state the question again? I'm sorry.
Do you take care of patients post VBAC, VBAC?
I think because I've been here the least amount of time, I think I may direct that to one of the other midwives.
I'll answer that. I don't know what you mean by post VBAC. Now, we do not take care of patients currently that are planning a VBAC. Which would be post previous C-section. So if somebody's had a C-section and would like to have a VBAC, our practice of midwifery and physicians do not take care of those patients at this time. There are some other providers in the community, and when we have patients that are interested in that, we're happy to give them those resources and let them investigate those options.
Great. Thank you. Okay, this question, and probably any of you can, well, I know any of you could answer this. This person asked, what if I plan to have an unmedicated birth and then I change my mind, or I feel I can't do it after all? What are my options? Joy, would you like to answer that one?
Yes. You can birth however you like, is what I tell my patients, whether that's unmedicated or with an epidural. We have IV options that you can have that isn't the full epidural, but it kind of takes the edge off the pain. At St. Francis specifically, we're trialing nitrous oxide, where you hold the mask to your face and then you take the medicine off when you have enough. So that's something that we offer here at St. Francis that's not available at the medical center or at Piedmont. That's a good option for a lot of our low-risk patients who don't want the full epidural effect where you're stuck in the bed, but at the same time they want to take that edge off of their pain.
That's very interesting. So they can actually do the nitrous oxide, and take it on and off as they see fit. Isn't that the same thing they use in like dentist office when you're having a procedure done? Is that the same kind of thing, or is it?
Yes,
it
is.
It's it's the same thing.
That is really cool.
It's a very good option, especially if you get to the very end of labor and just need something to help you relax and get through the last little bit. It has essentially no effect on the baby. It's got a very short half-life, so it wears off very quickly. It is patient driven, so the patient has to hold the mouthpiece themselves. Nobody else can do that for them. And for most patients that have used it, they felt like it gave them just enough relief to get them over that hump and able to push their baby out without having any other intervention. So it's been a really, really wonderful tool for us.
It's also a really good option for women who go completely unmedicated, but then need to have a obstetrical laceration repaired. They can use that in addition to local analgesia. They can use that to sort of help them relax while we're doing that repair too.
Great. That is really cool. Thanks for mentioning that. So another question we have, can I have a water birth at St. Francis?
Unfortunately, we don't offer water births, but we do allow women to labor, you know, in the shower. So we don't offer water births, but we can do the shower.
Okay, awesome.
So, yeah, women are
And they
able
can
to
sit in the
birth.
tub too.
Yeah, they can sit in the tub during labor, but when it's time for the women to actually push the baby out for birth, we prefer them to be out of the water at that time. We have intermittent monitoring, so if you are away from the monitors, we'll do it intermittently and still hear the baby's heartbeat. But for the actual delivery, we'll have you out of the water.
Great. Okay, so do you care for women that are expecting multiples?
So we do take care of women expecting twins, but higher order multiples like triplets or more than that, those patients fall outside of our scope. And so we do refer those over to our physicians. And we do offer, you know, vaginal birth of twins, depending on the risk factors and the position of the babies at the time of delivery. So that may be an option for you. All twin deliveries are, well, all midwife patients who are having twins will also be attended by a physician at the time of delivery, so that if things become complicated or need to move to a C-section or an assisted birth, then we do have our physicians in the room with us. Whereas typically with a normal, you know, singleton vaginal delivery, the physicians don't have to be present for that. For the twins, we do have them present because those are certainly a higher risk delivery. So depending on the circumstances and the mother's preference, we do take care of multiples, we take care of twins, and we do offer the option for vaginal birth.
Great. This question is directed to Melissa Terry Fish. How has midwifery care changed over the course of your 30-year career?
Ooh, you're making me sound old, Becky.
You're not old.
It has changed tremendously, I will tell you. Number one, technology has changed tremendously. The things that we're able to do now that we didn't do 30 years ago are significant. I didn't even know the term maternal fetal medicine 30 years ago. I'm sure there may have been some somewhere, but certainly not where I worked. And so having access to maternal fetal medicine for high-risk patients is certainly a change. Ultrasound has changed tremendously. We diagnose lots of problems by ultrasound now that we weren't able to document 30 years ago. Alpha fetoprotein testing, genetic screening in utero, all of those things were just becoming available when I went to midwifery school. So that's all new, and being able to do the prenatal diagnosis of genetic disorders. The Novi monitor is totally new. I mean, the list is endless. I can't tell you, but probably one of the main things that I feel like has changed in 30 years, unfortunately, is the health of women. We have more and more patients who have pre-existing medical conditions, diabetes, high blood pressure, primarily. Obesity and morbid obesity are all significant maternal complications that affect the health of their pregnancies. And, you know, if there was anything in this life I would like to change, it would be the health of women in general. Having people have better information and knowledge about nutrition and the importance of adequate nutrition, adequate exercise. I think that's probably the biggest thing. I don't know who sold somebody on the fact that Gatorade is the best drink to drink. That's the worst thing that ever happened to women. Nobody, unless you're out sweating on a football field, needs to drink Gatorade on a daily basis. And so those kinds of things are how I spend a lot of my day, is talking about how to stay healthier, how many vegetables you need to eat, cutting down on sugars and sweet beverages, exercising regularly. And granted, I'm not the most diligent one about that, but I feel like, man, I get a bunch of steps in and squats, getting up and down off those exam stools every day. You know, that should count for something. But we all say that our work environment exercise really doesn't count. We need to be out moving our bodies outside of work, if nothing else for our mental health. A 30-minute walk, and it doesn't even have to be at a fast pace, does so much to increase your vitamin D levels if you're walking in sunlight. Mental clarity, release endorphins in your brain, which help with your serotonin levels and your outlook on life, and you know, works toward decreasing depression and mood disorders. There's so much research being done into diet and depression, diet and anxiety, and those kinds of things that we can make a difference without a drug. And so there's so many things that women can be doing. Lifestyle changes, meditation, yoga, stretching, walking, you know, so many ways that we can impact our own health for the better without medication. And I feel like so many people reach for medication to try to fix things, but the reality is we've got the power to fix so many of those things just in lifestyle changes. I tell patients all the time when they're complaining about anxiety, anxiety is God nudging you. God is nudging you, telling you, you need to make a change in your life. If some part of your life is making you anxious, then this is God saying, fix it, change it, make it better. And we as women have the power to do that for ourselves. Now, some of us need a spirit guide, basically, or a coach or a counselor or whatever you want to call it. But many of us need to make a change in order to get over some anxiety and depression issues. And diet and exercise can be some of the very first parts of that. So that's one thing. Midwifery covers all of those things. And so when patients hear us harping about the number of big gulp cups they drink every day of soda, it's not because we're trying to be mean. It's because we know that their health is very much dependent on some of these lifestyle issues. So many of our clients live in what I call a food desert, where they don't have a good close by grocery store that they can access on a regular basis for fresh fruits and vegetables. And so they end up reaching for junk foods, convenience foods. Drive-through is such a big deal. I can't tell you how many patients I've had over the years who tell me that all their meals come out of drive-through windows. And I tell people all the time, if it comes out of a box, a package, or a window, you do not need to put it in your mouth when you're pregnant. Meat, chicken, fish, vegetables, and fruits. You've heard me, all of you have heard me say this.
I think
so, those are probably the biggest changes I've seen.
Well, that's a very good response, and it really kind of leads into one of the next questions. You know, what if I'm diagnosed with gestational diabetes? Can the midwife still see me and treat me and deliver my baby?
So we do take care of women who have gestational diabetes. One big difference is women who have pre-existing diabetes are a much higher risk during pregnancy, and so those women do fall outside of our scope of practice, and we would refer them over to one of our physicians in the group. But for women with gestational diabetes, a lot of those women are able to control their blood sugars very well with diet, nutrition, exercise, that sort of thing. So we do have some referral sources that we send those patients to specifically for more of an extended nutritional class and instruction, screening, that sort of thing. But then we also give them feedback when they come into the office each visit. We'll review their blood sugar logs, help them tweak some of the things that they're eating to help them control those blood sugars better. If we do have to move up to where they're on a medication, as long as their blood sugars are pretty well controlled on, a lower dose of medication or maybe just one type of medication, we're still able to deliver those patients. Oftentimes we will have our physicians on backup just because there are a higher risk of complications during labor and birth with a diabetic patient, but we are still able to deliver those women with gestational diabetes. But we do know that those women also are at a higher risk of developing, long-term chronic diabetes. Doesn't always happen, but we do like to screen those women again after their 6-week checkup to make sure that their blood sugars have returned to normal. And then, after they turn 40, they certainly need to have regular screening with their primary care provider or even a, hemoglobin A1C here with us if they're coming for us. To us for their annuals, we can do that just to make sure that their blood sugars are staying normal. If they do have gestational diabetes in one pregnancy, they are at a higher risk of developing that in subsequent pregnancies. So we do what's called an early screening at the beginning of their pregnancy to make sure that it's normal then. We still have to do that 26 to 28 week screening. So that does mean you have to get tested twice in pregnancy, but it is, again, like Melissa said, we're not doing it to get on your nerves or to make life hard for you. We're doing it because we know that these things make a difference in your health and in the health of your baby and your family. And so we want to do all of these things that are shown to help you to have the best pregnancy outcomes possible.
Thanks, Melissa. This next question, I think, Bettina, this would be a great question for you. The question is, do you provide care or medication for women suffering from postpartum depression?
Yes, we do. There are different options for managing a woman who has postpartum depression that ranges from putting them on medications for postpartum depression, or if a woman chooses not to go the medication route, we can also look at psychotherapy or therapy, counseling, something along those lines for postpartum depression.
Great, thank you.
I wanted to say that we do screen for depression before the pregnancy, during, and then in the early postpartum, and then at the routine 6 weeks postpartum. So we do a thorough depression screening on all our pregnant women.
Great. That was going to be the next thing I asked Joy was, how do you kind of follow through with that after someone has delivered? And you just answered it through the screening. The other question go ahead.
Before we move on from that, we do have a new project that we're developing that has a more robust referral and feedback system with some of our local psychiatrists, psychologists, the clinical counselors and therapists, that sort of thing. So if we have somebody who needs to be referred out for care, we have people that we've referred to in the past, and we're developing, like I said, it's sort of a more robust system to offer to our patients so that we make sure that we have comprehensive care and follow up for all of the women that we take care of.
Great.
Yeah, we just want women to know that postpartum and peripartum mood disorders are common, and we can talk about it. You don't have to think it's normal, and that we're here to help you and figure out what's going on, if it's the regular baby blues versus something more that we need to treat and diagnose.
Great, thank you. So the next question I have is, what is the difference between midwifery and doula services? Joy, would you like to answer that one?
Yeah, sure. Usually doulas are not certified. They usually don't have to go through a formal college course or grad school. They may have certification courses that they're certified to be a doula nationally through DONA, which is the organization. They usually don't have a medical background, so they can't diagnose, they can't treat, they can't deliver babies. or give any medical advice, actually. So what they are good for, and the studies show that if you have a constant support person at your birth, such as a doula, you have a lower rate of C-section. So they're really good to be a constant support in labor, during pregnancy, and even in the postpartum time. They're for support and encouragement, just somebody to kind of reflect ideas and bounce off, the care of yourself and the baby. But medically, they're actually not supposed to give any medical information. They refer all that information to the midwives.
Great. So, so would a doula be considered the laboring woman's, significant other, or the one person, the support person that they can have, or are they considered, part of the, not, I shouldn't say medical team, but part of that support team? Because I'm sure that's a question people have. If I have a doula, can I also have my husband or my significant other or my support person in there with me?
I think right now, right now I think it's one support person, the doula would be a support person. So unfortunately, with the changes with COVID, the one person is either going to be the partner, family, or the doula.
Great. Okay. So we have another question. What are your main concerns for just turning 36 and being pregnant? So if you're 36 and you're pregnant, what concerns or things do they need to be looking out for?
So women who are 35 at the time of their due date or older are considered advanced maternal age. And there really is a higher risk of some complications like high blood pressure, gestational diabetes, but also there's a higher risk of genetic anomalies with the baby. Because if you think about it physiologically, a woman is born with all of the eggs that she'll ever have. And so when she's 18 and having a baby, or 25 and having a baby, her eggs are only that old. And so the genetic material is fresher, relatively speaking, than a woman who is older, so 35 or 40. Like I mentioned earlier, we do have some women who are having babies in their 40s. And so those women, their eggs are older. And so they're more likely to have the genetic material to not be as fresh as it was. So they are at a higher risk of having babies with genetic anomalies. And so there is some extra testing that we offer those mamas if they're interested. As far as genetics go, we don't require genetic testing for anybody, high risk or low risk, but we do offer that based on their risk profile. And so if they are 35 or older, but especially if they're 40 or older, we offer those tests and encourage them to consider those options and what the results would mean to them. Some women don't want any testing at all because they don't want to be anxious about it. Whatever comes, and they're going to deal with it when it happens. And some patients want all the information as early in pregnancy as possible so they can make the decisions that they need for themselves and their families and their health care along the way. So we do offer some additional testing for women who are considered advanced maternal age so that they can have all that information to make the decisions for themselves.
Great. I think I'll direct this next question to Bettina. What type of birth control options are offered?
So, of course, with birth control, there are natural methods and there are hormonal methods as well. Natural family planning in terms of watching, like when you ovulate and things of that nature. Then on the hormonal side, you do have birth control pills, you have vaginal ring, you have the patch, and you have the depot injection is also an option, as well as what's called, there's a tiny rod that you can put in your arm just under the skin, which is called the Nexplanon. And then you have your IUDs, the Skyla, there's the Mirena, Liletta, and Paragard IUDs. So a wide range of birth control options. And I didn't add, for those who don't want any type of hormonal birth control, who don't want the natural family planning method, you can do condoms as well.
Sorry, I was muted. So the next question is a question about adoption, and is it supported through midwifery?
Absolutely. Anytime we have a client who is conflicted about having her baby, we always talk about adoption as an option, and we are great supporters of adoption. And there are lots of paths to adoption. Many people have a private adoption plan in mind where they have identified a family relative or someone in their circle of friends that wants to adopt their baby, and we'll be supportive of that and try to include that person as much as the birth mom wants them included in the prenatal care and birth process. There are clients who want an anonymous adoption, and we can offer them several different options as far as going through an agency or going through the Department of Family and Children's Services, or other resources that we've identified in the community as a option for placement of babies. Some of the most wonderful, I call them birth stories still because it's the birth of a new family, but a couple of the most wonderful birth stories I've been a part of have been adoption stories that those experiences have been some of the clearest moments in my mind that God is in charge of all of the things that we do, in the way that the pieces fell together and worked out for the greater good of the baby, number one, but the mom and the birth family. So yes, absolutely, we are champions for adoption, no matter how it happens.
Great. Okay, so next question. What are the options for anesthesia? Melissa Hatter, would you like to answer that one?
Sure. So I think we kind of briefly touched on this, but I'll sort of go into more detail about what each option provides. There are what we call non-pharmaceutical methods of pain management in labor. So that would include laboring in the tub, which is available here at St. Francis. You can labor in the shower if you want to do that. Just have the little shower head running over your back or on your legs. Position changes are really great. We do have those big yoga balls that we let patients use if they don't have an epidural and they want to get up and sit on the yoga ball by the bedside. Sitting up in different positions in the bed, sometimes squatting, side lying, hands and knees, that sort of thing can provide some pain relief just because it gets the baby off of some of those tender parts in your pelvis. So those things are all really great. Massage is good. Music therapy, turning the lights down, sort of creating that natural homey feel to the labor and delivery room so that patients can relax, because we know that tension leads to increased pain, which leads to increased anxiety, which turns around and leads to more tension. So that's just a vicious cycle that we try to break by, encouraging patients to develop an environment in their labor room that encourages them to relax and to cope better with the pain. So those are non-pharmaceutical options. And then the pharmaceutical options that they mentioned earlier, the IV pain medicine usually takes the edge off, may help you sleep, especially if you're kind of in a prolonged early phase of labor and you're just kind of getting tired, you need some rest. So the IV pain medicine will help a lot with that. It doesn't last as long. So, some women find that it doesn't provide as much relief as they need for a long period of time. And so that's something that some women try and, it's not as good for them long term. And so they may switch to an epidural, which is fine. The epidural is a sort of a block that the CRNA, who's our registered nurse anesthetist, will place for you while you're in labor. They put a little catheter into the space so that you get a continuous infusion of medication. So that lasts all the way through delivery and through any repairs that may need to be done as far as like lacerations or anything during childbirth. It makes you numb from your belly button down is kind of the general idea, but there are sometimes little hot spots where you don't get completely numb. So again, no guarantees. It's not 100%, but most women do get really great relief with an epidural if that's what they're wanting to do. Unfortunately, you can't get out of the bed anymore once you have an epidural. And so some patients prefer to avoid the epidural because they would rather be up, mobile, around the room, that sort of thing. Repositioning is still possible. So side lying, that sort of thing when you have an epidural, just to keep the baby turning and rotating down the pelvis. And then the nitrous oxide, like they mentioned, can be great just to take the edge off. When you put the mask on your face, you get pretty quick relief within a few seconds. You'll start to feel that. And then when the contraction's over, you take the mask off and it metabolizes pretty quickly. Put it back on when you have a contraction. And so it's patient controlled. She can use it as often or as much as she needs to. And then if she feels like things are getting better, she wants to get up, move around, she can lay it off to the side and be done with that for a little while. So those are the options and kind of what they're used for and what their effects are. Great.
Thank you. So this question, I think I'll direct this one to Joy. The question is, what happens if there are complications during my pregnancy or during labor? That's probably a broad question, but I think it's in general, what happens and what options are available if that happens.
It'll depend on what type of complication it is. If it's something that requires more ultrasounds and consults, we can send you to the perinatologist in town, who can follow up on certain abnormal labs, genetic screening, and other maternal fetal complications. If it's during labor, we can manage certain complications, but a lot of times we have our backup OBs who are on call with us. So if we needed a C-section or an operative vaginal delivery, such as with a, suction or forceps or anything like that, we could call our backup OB who would kind of be there for the delivery as well.
Great. Okay, so this next question is, and I realize this is probably a question that, is pre-COVID and post-COVID, do you work with birth photographers?
We love birth photographers. Yes, I mean, we've certainly had lots of birth photographers at births for years now. I think, birth photographers are a wonderful option for women pre-COVID. They document moments that make the family freer to just experience the moment and then be able to go back and see things that were happening or emotions that were expressed, and really relish those moments. So yes, the birth photography community in this town is great. Unfortunately, with COVID, with us only letting one person in, that has not been possible. And our nurses have stepped up phenomenally. When they are not too busy, an extra nurse will come in the room and grab somebody's cell phone or camera and snap some shots that the family can treasure for a lifetime. Granted, they're not probably quite the camera angle or artistic eye that some of the birth photographers have, but they are certainly treasured moments all the same. And that certainly has been one of the hard parts about COVID, is not having those moments able to be captured, especially for families that have done it with their other children. To have one child that doesn't get it is disappointing. The absence of grandparents or special aunts or sisters at births has also been a disappointment for many families. But I will tell you, there are equally as many families who have felt that their private couple time with just their new baby and no interruptions from other family members and no interruptions from other children, to be able to focus on just that triad, the mom, the dad or significant other, and the baby, has provided a much more restful environment for them in the hospital and allowed for a smoother start to breastfeeding, a quicker recovery due to more rest without the interruptions of visitors. And so in many ways, it has been a blessing to as many families as it has been a disappointment. So there's my answer on that. But yes, we love birth photographers.
I think that's
and I think as much because they capture us doing what we're so passionate about. When I look back at somebody's birth and see the joy on my own face or Melissa Hatter's face or Joy's face, and I don't think I've seen any of Bettina yet because it's mostly been COVID time since Bettina's been here, but those moments of joy on our faces reminds me how much we love what we do and how important the work is to us. And those are just fun for us to see too. So.
Yeah, I have seen some beautiful photos taken at some of the most crucial moments, and they just truly are beautiful. So I would agree with you. We are almost at the top of the hour, so we're going to wrap this up, but I would like to give each of you the opportunity, if there's something else you want to add that maybe we didn't cover that you get a lot of questions about, or you just want for everyone to know, I'll give you the opportunity to do that now. And we can start with Melissa Hatter if you want to go, and then we can go to Bettina.
Sure. So I think we've pretty much covered a lot of the basics about midwifery, and I hope that if anyone is interested, even in just doing a telemedicine conference, we're able to do telemedicine conferences for new patients and established patients. So if you have any questions, especially concerns about preconception counseling, that's another thing that's really important in the health of women, is to talk about your current health status before you get pregnant so that we can help you determine if you're on medications that are unsafe, or things that may need to be changed in your lifestyle, alcohol usage, that kind of stuff, getting started on prenatal vitamins, that sort of thing. So if anybody is interested in even doing a telemedicine conference because they, don't want to come into the office because of the risk of coming into a healthcare facility right now, we do offer those visits, and so give us a call.
Thank you. Anything to add, Bettina, that maybe you want to add to it?
The only thing that I want to say is so much that has been covered. It's just that I just always like for women to realize that they have a voice to relish in this moment when they're pregnant and they're going through the labor process, and don't be afraid to ask questions. We're all accessible. If there's anything that you don't know, you don't understand, don't be afraid to ask questions.
Thank you, Bettina. Joy, would you like to add anything?
Yeah, just that we're here for you. So even if you're not pregnant and not even thinking about pregnant, we do GYN care as well. So we love educating, answering questions. We want you to know your own body and your own health care so that everything's covered. So we're here for women, pregnant and non-pregnant.
Thanks, Joy. And Melissa Terry Fish, anything to add?
The only thing I would add is that we are so blessed to have a full team now, 24/7 midwifery care, which we had not had for several years. So we're thrilled to be able to be back to offering 24/7 care. We're also blessed to have a great group of physician backups that are available to us 24/7 by a phone call, in person, however we need them. They are responsive and ready to be a part of your care when they are needed. And they, certainly serve a great purpose for us and for you in that sense. We want everybody to be able to find the provider that they feel like they fit with. And so sometimes patients don't feel like they fit with a midwife and they transfer over to a physician care, or potentially physician patients that would like to try an unmedicated birth with a midwife. And our physicians are very responsive to you making that change as well. And the other thing is, we do have all of our patients pregnancy-wise rotate throughout the midwives so that you are familiar with each one of us, and have had an opportunity to interact and ask questions from each of us, so that you're comfortable whichever one of us ends up being at your birth. We all have different personalities, and you may have a favorite, and that's all great. But every one of us is capable and safe and can provide you with the kind of experience that you're hoping for, and within the realm of safety. And then the last thing I would like to say is, if anybody is ever interested in having a women's health speaker at their community event or at their church group or women's group or teen group or whatever, we're available for those kinds of things as well. And all you need to do is call the office and get that information to one of us, and we'll be happy to fill your request.
Well, great. Well, you ladies have done a wonderful job. We appreciate your time. If anyone has questions about midwifery services at St. Francis, they can visit our website at mystfrancis.com to find out more, to schedule an appointment. We also have recorded this session, so we'll make it available on our website and on social media. But you ladies have done a wonderful job, and I know this is a lot of good information for our public out there. So thank you for joining us today, and we are going to end it. Thank you so much.
Thank you.
Thanks, Becky.
Thank you.
Thank you.